Hello, anatomy colleagues. This is Dr. Alsop, and in this last learning objective for this session, we're going to focus on the abdominal wall. Now, this is a complex area, so we're really going to analyze both the structural as well as the functional components of the anterolateral and the anterior abdominal walls. And we're going to have a specific emphasis on the significance in minimizing neurovascular injury during surgical procedures. So I actually want to start with the second part of the learning objective first, because abdominal wall anatomy is so important for understanding, as this is a relatively common area for surgical incisions, as this can access, obviously, as you would imagine, abdominal viscera, but also pelvic viscera and thoracic viscera. In other words, surgically, the abdominal wall is hugely important. Specifically, the wall forms the basis for the creation and closure of abdominal wall incisions and also hernia repairs. So on this image on the right, you can see the outline of some of the more common surgical incisions. And hopefully you notice a great deal of these are in the abdomen. We'll actually discuss a few of these, certainly not all of them in the lab. But just looking at this image, if I were to do a count, you would see the abdominal wall is on the higher end for typical incisions. Now, understanding the wall and its anatomical relationships, that really can help in terms of minimizing the risk of neurovascular injury. So if you know where the artery and nerve is located, typically you can avoid it with your incision. Also, picking the right incision through specific and intentional structures can ensure that you have optimal closure, as well as actually minimize the scarring that will come after the fact during the healing process. And then when you're picking that right incision, that can help in terms of avoiding, obviously, the neurovasculature, as we mentioned, but also the visceral structures as well. So we're really trying to avoid damage to deeper structures. Obviously, if you're making an incision, you have to cut through some things. It's just you want to minimize the amount or the specific regions, particularly if there's a good amount of neurovasculature there. So this will be your first introduction, and we'll return to the abdominal wall later in the M1 year, and then we'll return here again in the surgery clerkship and beyond, just based on the importance of this region. All right, so let's actually talk about what makes up the wall. Specifically, we're going to talk about the anterolateral wall. So if you kind of rub your hands down the side of your abdomen, that's what we're talking about, that general region. And I actually don't have here on the slide, but obviously you're going to have skin and subcutaneous tissue in this region. Just deep to the subcutaneous tissue are going to be three thin sets of muscles, colloquially referred to as the obliques, based on the organization of their muscle fibers. From superficial to deep, you're going to have the external oblique, the internal oblique, and the transversus abdominis will be the deepest. And each one of these muscles have their own deep investing fascia. So deep fascia, common theme, that's going to come up throughout the year. Now, the muscle fibers of the external and internal obliques, you can see here on this image on the right, run diagonal to one another or perpendicular to one another. And the deep transversus abdominis muscle actually runs, as its name would suggest, transversely. So the directionality of the fibers are hugely important in the major function of these muscles, which is really to compress and support the abdominal viscera. It can play a role in terms of lateral flexion as well of the trunk and of the abdominal region, but really the major role is to compress that abdominal viscera. Now, the flattened or sheet-like tendons of these oblique muscles are actually referred to as an aponeurosis. So when you have that flattened sheet-like tendon, aponeurosis is the term for that. And they will intermingle and form the tough rectus sheath, which is going to be located anteriorly. It's hard to miss if you're looking at this image here on the right. It's this very white opaque region. So let's talk a little bit more about the rectus sheath. So as I mentioned, it's located anteriorly. It's hard to miss due to the opaque white appearance in comparison to the muscle fibers next to it. And it importantly will enclose the rectus abdominis muscle, which is going to be the anterior abdominal wall muscle. And because it encloses this muscle, it actually has anterior and posterior portions. Importantly, the inferior posterior portion of the rectus sheath is incomplete. So this is a place of inherent weakness in the abdominal wall because you don't also have that inferior posterior portion of the rectus sheath. There is no rectus sheath there. Now running down the midline and middle of the rectus sheath is an even more a whiter and opaque line called the linea alba. It is here that the aponeuroses of the right oblique muscles interweave with the aponeuroses of the left oblique muscles, and that is why it is more opaque because of that intermingling right there. It will extend from the xiphoid process, or the bottom of the sternum, to the pubic symphysis, or the anterior portion of the pelvic girdle. So a fairly long expanse. Now, this region is important for two major reasons. As discussed, this is the medial-most anchor for musculature in this region. Super important. So that's important in terms of stability and structure of the abdominal wall. But also importantly, the linea alba is going to lack neurovasculature. So if you take a moment and think, would it be good to make an incision through the linea alba? Well, your first thought might be, yes, it avoids that neurovasculature. That's a good thing. We know we want to stop that. We don't want to do that. But then you might need to stop and think, but if I cut through the linea alba, it could disrupt the stability of the abdominal wall, as it is that anchor point for the anterolateral abdominal muscles. So you really have to think through, as a surgeon, these types of pros and cons, because one region is not going to have any risk of injury. There's going to be neurovasculature in regions. There's going to be deep structures. There's going to be stability issues. So you have to think through the goal of the surgery, how much access you need, and of course, the deeper structures there. All right, let's talk about that anterior most abdominal muscle, the paired rectus abdominis. If you look at this image on the right, the left, yes, I said left. Remember, this is patient left, not your viewing left. So this left rectus abdominis muscle is visible because the left portion of the rectus sheath has been incised and opened. So if you look at the right side, you don't see the rectus abdominis because the rectus sheath is occluding that view. So you can get an idea of what we mean when we say the rectus sheath encloses the rectus abdominis. So you can really only see it by incising or opening up the rectus sheath. This is a straight or vertical muscle. Rectus actually means straight. And similar to the oblique muscles, the rectus abdominis will function in compressing abdominal viscera. That's a very important function of the musculature here. Rectus abdominis will also play a role in flexion of the trunk. Now, traversing horizontally in the rectus abdominis are structures called tendinous intersections, and these serve to anchor the muscle to the anterior portion of the rectus sheath. So, if the rectus abdominis hypertrophies, say through specific exercising that affects the rectus abdominis, and an individual has relatively limited amounts of the subcutaneous tissue in this area, the muscles will bulge out around the tendinous intersections. And those tendinous intersections stay the same size. And that's what would give that 6-pack or 8-pack appearance, depending on how many tendinous intersections an individual has. But really, functionally, for all individuals, these tendinous intersections are serving to kind of anchor the musculature to the rectus sheath. All right, let's talk a little bit about innervation to this area. And the most characteristic thing about the innervation of the abdominal wall is that there is a regular and segmental innervation. So one spinal cord segment and spinal nerve will go and innervate one segmental portion of the skin or musculature. All right, seems pretty simple, right? Intuitively, you may think that this is how much of the innervation happens throughout the body because it's the simpler version. But it's actually the more complex process of plexus formation that will be the standard throughout most of the body, particularly in the upper and the lower limbs, but not just there. And so what this means, and we will return to the concept of a plexus quite a bit throughout the curriculum, is that fibers from different spinal cord levels, so different spinal nerves, will mix to form these named nerves. So nerve branches from multiple spinal nerves will intermingle to create these named nerves and then go innervate portions of the skin as well as, of course, musculature. But again, it is this more segmental innervation that you see in the abdomen. Specifically, it will be the ventral primary rami, or the VPRs. We'll talk more about this concept in the session the next session. So it's these first anterior branches of the thoracic spinal nerves, 7 through 12, so T7 through 12, as well as the first lumbar spinal nerve, or L1. T10, so thoracic spinal nerve 10, is a nice place of reference because it will serve the territory at the level of umbilicus, or the belly button. So you can kind of figure out from there, T7 through T9 is going to serve the abdominal wall superior to the umbilicus. T11 through L1 will serve the abdominal wall inferior to umbilicus. So if you know T10, you can get a good idea in terms of the regions elsewhere. All right, you can't talk innervation without talking vasculature. There is, as you might imagine, a lot of superficial vasculature supplying the skin in this area, but we're going to focus on the dominant deep vasculature in the abdominal wall. And these are the superior and inferior epigastric arteries. Of these two, it's really the inferior epigastric that is the major supply of this region. You can actually notice if you're looking at this image here on the right that the inferior epigastric is quite a bit wider, more noticeable than the superior epigastric, because again, it's serving more of this region. I also want to note that these arteries are branches from two different sources. And these two arteries are from two very different areas. So the internal thoracic artery, sometimes you hear it referred to as the internal mammary, is located in the root of the neck in the thorax, whereas the external iliac, for which the inferior epigastric is a branch of, that external iliac is going to be located in the pelvic girdle region. So those differing sources are important because of this concept of arterial anastomosis. So arterial anastomosis, or connections, communications between this vasculature. This anastomosis will allow blood flow to continue in cases where a pathway is obstructed. So say the superior epigastric artery is compressed. You will still have blood supplied to the abdominal wall because of the anastomoses between the superior and the inferior epigastric arteries. Now, that being said, it is rare for an anastomosis to handle long-term occlusion or compression of an artery, but enough to slow down issues that can come with little to no blood supply to an area in the short term. If you think in the bigger picture, say there's an occlusion in the internal thoracic artery, that would directly affect the superior epigastric artery, because superior epigastric artery is a branch of the internal thoracic. So presumably you wouldn't have any blood supply to the region that the superior epigastric tends to supply. But the abdominal wall would still have blood supply in that short term in that region because of the anastomosis with the inferior epigastric artery. It will play that role for the short term. And also, inferior epigastric artery wouldn't be affected because it's not a branch of the internal thoracic artery. It's a branch of the external iliac. So you'll hear us talk about anastomoses a lot throughout the year. They're all over the place, and that's a good thing functionally to allow for blood flow, even in situations of temporary compression or occlusion of an artery. So again, a concept that will come up quite a bit, very clinically important. Excellent. We have reached the summary slide. Again, a bit longer of a learning objective, more to know and more to review. So if during your review you have any questions, please don't hesitate to ask. Thanks for your attention.